and on behalf of the Hunter branch of the Royal Society of New South Wales, a very warm welcome to this, I think, the last in our series of lectures for 2024. There will be more in 2025, but this is the last one in the 2024 series. And I should begin by acknowledging the traditional owners of the lands on which we meet and pay our respects to elders past, present, and emerging. So tonight we have a great privilege of welcoming Francesco Paolucci to the podium. So Francesco is a Professor of Health Economics and Policy at the University of Newcastle, and he also holds a chair at the University of Bologna in Italy. He is Associate Dean International of the College of Human and Social Futures and Coordinator of Value in Health Economics Policy Group. He was formerly head of health policy at the Sir Walter Murdoch School of Public Policy and International Affairs at Murdoch University in Western Australia. He was also formerly an advisor to the health minister in Chile and a member of the Italian Technical Committee for allocation of the national health budget. His work includes a large number of publications, over 100 publications, and he has also authored a single author book on health economics. He's won many prestigious awards and holds ARC, NHMRC, and EU grants, and that tells you something about his international standing in the field of health economics. So, we are now, I think all of us, many of us in this room, entering a stage of our lives when we are having to make demands on the health service, and as a society, we all, indeed, most advanced societies are aging and making demands on the health service. So as we face our dotage and think about the kind of health service that we need, I think we all recognize that providing healthcare is a very expensive thing. And the question that we've put to Francesco is, how can we afford the health service of our dreams? So Francesco, to answer that very difficult question, the floor is yours.
So thank you all for being here tonight. Thank you, John, for the wonderful presentation, and of course, George, for working together on the theme as well as a little bit the logistics. Now, when I discussed and looked at the title the first time, you can think in many ways about this question. As an economist, you can think about this in at least three ways. Mainstream economists would answer this question as in very simple terms. You just can't. It's impossible to actually achieve that. Other economists, I would say, more progressive, that are called extra welfareists, they would say we can do this only considering healthcare as a pure public good. And we have done that for many, many years. Then there is a third breed of economists, I would say I belong to that group, that actually believes that we can dream big and maybe try something innovative by combining the lessons of history, which I believe in social science, in public policy, it's really the only science that we can rely on. Now, when you ask that question, which has dream in it, I warn you, I'm an economist, so typically we are very capable of transforming dreams in everyone else's nightmares. But I'll try my best to bring you in the economics world and, of course, telling what a dream could look like, at the very least, in the way I see it. So I'll look at healthcare system as they are currently, major trends, and of course, come at any point in time with questions. And I will briefly discuss how this dream or nightmare looks like, where we are at right now. Then I will look at history. I think it's really the biggest lesson for us if we are to make any reasonable long-term decision, which is the hardest one in public policy, that can really produce really a public policy change that it in fact could be achieving the goals that I consider the dream goals of a healthcare system. And finally, I will look at what I call a model of convergence. This is more literature that I'm thinking of, and I'll talk to it a little bit. And I will discuss it, of course, in the Australian context and see whether we can actually start working actively on it. I mean, not that we haven't been doing that, but of course, when there is economic policy, there is also politics, which is an interesting beast in itself. Now, the first point to look at as an economist is always costs. It's clear that when we look at healthcare and we look at the developed countries or OECD countries, there is no good news. This is only healthcare. I actually took out what we refer to as long-term care because otherwise the graph would just be exponentially shooting up. This means that when it comes to healthcare, and it may be a very good thing, a finance person will look at this graph and be horrified. And in politics, typically we have more finance people than economists. And economists would come home with this graph and say, yeah, we're spending more, which means that perhaps we are spending less on things that we actually consider less important for you to choose, right? On the other hand, this spending is concerning because we do have important competitive objectives as society, climate change challenges, defense, security, safety, and so on. The other big macro trend is, of course, aging, and John clearly put it. And this is a function of the success healthcare systems have had. Not only the production function of health is very complex, it relates and talks to education, also quite undermined in public policy these days. It also is a function of wealth in and in itself. In some contexts and countries, in fact, where there is no healthcare system like the developing world, an improvement in income conditions can actually yield great health outcomes. But we are, in the OECD, we are really dealing with an aging population trend. Some consider it a problem. Some are trying to, in fact, consider it in a productive, useful way. That depends as well on how you organize society, and actually you can find returns from aging societies. This is the third macro trend, the transition, which interests more and more developed and developing countries away from communicable diseases to non-communicable diseases. The key element here is that that transition imposes an organized healthcare system. So we're not only working in prevention, in control of disease, in vaccination campaigns, and so on, but we're also working on treatment of chronic long-term conditions, which can in fact last many, many years before becoming death-threatening, in some cases decades, and in fact they may be compatible with very productive lifestyle, which also puts pressure on the healthcare system. And finally, this is the most critical and under-discussed theme, although sometimes you hear about it, but I don't think we have ever experienced as a global community a healthcare workforce crisis that is the current one after COVID. At times, this shock in particular was asymmetric. So some countries experienced it, some countries didn't. So export and import of professionals with huge, ethical dilemma, especially if the import comes from low-income countries, was the solution for OECD countries. Now, every single country is facing this. The solutions are not easy. You need to train individuals. You have to people able to train the new workforce. And also you need to do that at a global scale. This is a supply side problem that at present in a global sense is the first, probably most important pressure point in terms of affordability of any healthcare system. Now, a little bit of the nightmare that continues, I would say. But it's important because then we can have a dream, or at least I tried. Now, the Australian healthcare system is very special. Its history is fascinating. It's the only system in the world that had a universal coverage enacted during Whitlam government in '75, and it lasted only 1 year. That was called Medibank. That government, in fact, there is a beautiful book called The Dismissal, was removed. And with that, also Medibank. For us, as Australians, to achieve universal coverage, we had to wait another 10 years in 1984. But that was just a tax levy. In fact, it produces only a support to medical and pharmaceutical services. Now, the underlying structure of the Australian system, because of its constitution, is equally complex. It's a federation. Services are offered and funded in a complex web of public and private mix. Many have described it for many years in the literature as a fragmented system. Some economists really like fragmentation. They call it vertical competition. That assumes a lot of things, but one of the outcomes of vertical competition, in fact, is that you have what now many economists are referring to a disintegrated system. So a system that has very little connectivity between, for example, the Commonwealth services, primary care, GP care, and hospital services, like the ones offered by every state, and private insurance, and out-of-pocket payments. And I think there is clear signs that support that connotation. The deficits that the states are facing these days are really scary, I would say, from an economics perspective. The technical word is really, in the debate with the states that I have, it's really about how do we get around the current budget crisis. How can we impose a new tax? And of course, all these things are in the press. You might have seen it in the last few days about our own New South Wales health government proposing to increase a levy that it's the ambulance levy to fund hospital care. Why? Because in the law, they're not allowed to actually enforce for all private insurers to pay any hospital levy, but they can enforce an ambulance levy. So this describes the complexity and the level of indirectness that we have in our instruments to actually do public policy. Now, very alarming is the out-of-pocket expenditures. This is a very strangely hard statistic. It's normally quite easy to find, but for many reasons in Australia it's very hard to measure. There are estimates that range between 22 and 27% of out-of-pocket spending on total healthcare spending. This is very alarming. The next country that you can think of in terms of similar out-of-pocket spending, it's actually Chile and Botswana. These are countries that they are in Chile is in the OECD, one of the last entrants. Botswana is clearly a developing country. So these are levels that start to alarm. It means that there is inequality. It means that people do not get access to care, to basic entitlements, and I'm sure all of you have seen this. This is also reflected in the political debate, with the waiting times that are clearly increasing to highest level ever. Closures of private hospitals, which has been historically an instrument for the public sector to rely on under pressure It's not doing that anymore. Over 60 hospitals have closed around Australia, some in our proximity, in fact. And also the private health insurance premiums are going up. So we're really in an inflationary, inflammatory phase. So not the dream situation. Of course, there is a bit of a good news about the level of technological innovation, which is very important. It needs to be part of the dream, but now it's really medtech and innovation that only few can really access on a consistent basis. Now, let's look at history. First of all, how does an economist think about the healthcare system of your dream? The economist of my type think about a healthcare system that has fundamentally 5 characteristics. First of all, it needs to achieve universality in coverage. That is a basic economic concept. It's about externalities. If I know that my neighbor or my far remote neighbor from Queensland cannot access a service that is readily available at a relatively low cost, that will decrease my well-being. I will be affected negatively, and that would manifest in many ways, including, for example, voting for another party. Okay? Now, that is despite the fact that healthcare is a private good. You know, if I consume it, you can't. So there is rivalry, there is competition for these services. So if we think about these as goods, as economists think about them, well, then universal access needs to be supported by government intervention, because markets otherwise wouldn't do the trick. The second important element is that in healthcare, and that is thanks to technology, which is a big part of the dream, you need choice. People have different preferences. I'm sure you've all had your encounters with the healthcare system. Some of you want to play tennis when you are, like me, almost 50, and all full of inflammatory points. Well, you got to go and do surgery, hips, knees, and so on. So there is a whole part of the healthcare system that has clear election. In fact, we call it elective services. Other parts, of course, that pertain to public health and emergency, that is where choice is more limited. It's basically, we do what we're told. But if you think about the prevention space, the elective type of care, and so on, you have a lot of options. Choice is critical in the economics, thinking about the characteristic of a dream healthcare system. Then there is a word that has a clear connotation in the public debate. Economists think about it slightly differently. It's a word it's that word there, efficiency. So we don't really have to think of it, although it's important, as cost containment, but rather value for money. And that is a clear, intimate connection with the idea of quality of life. So economists spend a lot of time to look at care, how it's funded, how it's delivered, in such a way that actually it yields a good return of that investment in terms of quality of life measurements. And that, of course, includes a number of dimensions: innovation, productivity, and also, importantly, incentive, because ultimately what we want is a system with good quality care. Now, how have we done as a society so far, if we look back? Now, I take you briefly on an historical journey, which I think it's quite important to understand, because I think the only element that is missing in the way we have approached this problem, that's why it's so complex, is the ability to consider all these goals at once and design a healthcare system of our dreams that is capable to produce tools and instruments from the public policy areas to actually achieve them at once. So I think it's possible. We have been working on the solution, which is the latter part of the later part of the conversation. But so far, healthcare systems have been really working, looking at one objective at a time. Now, this is a body of literature that I really like a lot. It's economic history in healthcare. David Cutler is the Harvard professor that started this stream. And together with a colleague from Bologna, Federico Toth, and others, Chiara Berardi from LSE, who was a student of ours here, they worked on this idea of reform waves. Now, the very first wave is the post-war reform wave. And that's where you learn that we never had healthcare systems until the British introduced the Beveridge NHS. In 1948, for reasons that I believe, reading the books, had nothing to do with healthcare, but rather with reconstructing a country that was devastated, a country that needed social cohesion, they chose, as an instrument of public policy, healthcare. I think it's a beautiful idea. Others have invested in education, you name it, but the introduction of the National Health Service has been the critical and foundational element of that rebirth. Now, what was at the heart of that reform? Universal access. Everybody is entitled to public services. They didn't even have hospitals, the day in which this reform was introduced. Not in the way that we know that the hospital system now. A number of other countries, so not the UK, they have built their healthcare system already for quite several years. Countries that were under the Bismarckian influence. So we're talking about mutual social insurance type of systems that you saw in Germany, in Belgium, in the Netherlands, in Switzerland, and then now you can see them everywhere. But fundamentally, the only difference between the Beveridge and the social insurance models was the fact that one collected revenues from taxations, the others from employment and premiums. And the NHS doesn't have choice. The others do have choice of purchasers of care. So in that 30 years, all OECD countries, apart from Australia, achieved universal coverage. So everybody had access to some care, quite generous, I would say. Now, Italy, of course, my own country, was late, as usual, so we introduced that in 1978, which you will see how counterintuitive it is, because in the 70s, many of you will remember, towards the end we experienced a terrible oil crisis. Conflicts, similar to some extent to what we're living today, also in terms of inflationary pressures. And Italy, really in the middle of it, decided to introduce the NHS, which was probably something that we're still paying in terms of our budgets these days. It's a country that has a huge debt. Now, the introduction of universal coverage, what it has produced, it has answered demands of individuals. Before, these individuals were accessing healthcare as a privilege, really. If you had resources, you could access healthcare services. The moment you introduce the NHS, the moment you introduce universal mandate to buy insurance for everybody in society, it's when people start consuming healthcare. What does that mean? It means that basically you have an increase in demand and an increase in prices overall. Coping with that in the middle of an oil crisis is hardly impossible. So after the 70s, for a good couple of decades, we had an incredibly harsh response to that expansionist era. And that was very much a pro-efficiency, cost containment, cuts, budget cuts, supply side mostly restrictions. Waiting times started to appear. If you look at the surveys in this literature around satisfaction, the satisfaction until the 70s was excellent. Towards the end of the 80s, the 90s, the satisfaction towards the healthcare system in all OECD really went down massively. So in these two waves, interestingly, two objectives were tried to be achieved: equity and efficiency. but efficiency only in terms of cost containment. In the third wave, some economies started to take interest. This is a relatively new area of economics interest. And in fact, around the 90s, in particular in the Netherlands and in the UK, two individuals, Alan Eindhoven, Wiener van de Ven in the Netherlands, and Julien Legrand, I don't know, he's actually British, but the name is French. They worked and thought about how can we start thinking about achieving these two objectives of efficiency and universality altogether. And from that moment on, and some of you would remember, several reforms occurred, from Margaret Thatcher to Tony Blair in the UK. Some reforms happened here. We introduced universal coverage. A lot of tensions everywhere on how to do this, of course, because we didn't master the tools. So that's our history. What have we learned from that history? What we have learned is that if we take each objective independently from each other, we clearly have adverse consequences or unintended consequences. If you look for universality, of course you have cost rising. If you try to curb your cost pressures, you start having more cost sharing, you start outsourcing, you start seeing the growth in private insurance. It's something until the 70s the OECD has never seen. Some countries, only Canada doesn't have private practice, but the rest of the world has this duality. Now, all these issues are temporary, ad hoc solutions. Rationing on the one side to save money, on the other side to grow the private sector. If you do that, you decrease equality automatically. There is no way around it. How can you prevent that? Well, then you introduce regulations sometimes, but they are not well aligned and they perpetuate the situations in which we are in at the moment. Obviously, what you also have, and this is important to point out, when a system is around for a long period of time, you create power bases. And typically in healthcare, that's in the hands of supplier, because we as patients or consumers, we don't really fully know what we're being offered to consume. So it's quite important to realize, and this is hard, this is hard for individuals to really look at where the power base is in this complex interaction, because we tend to look at insurers, at payers, at purchasers, but really the owners of information and decisions are providers of care. So we have to balance the power structure over time. Otherwise, we have a lot of adverse consequences. Now, let's look ahead. How can we do this? How can we dream to actually combine these features to achieve these multiple goals at the same time? I mean, sometimes the solution really needs a very simple recipe of ingredients, right, to kind of come to a good outcome. The basic idea of this concept of regulated competition, on which several of us are working on in a number of different institutional contexts, basically refuses the idea that markets can do it all, but recognizes their value if they are markets, so where power is diluted, decentralized, not concentrated, and effective, efficient regulatory intervention in an integrated way. So without competition between jurisdictions, without competition between public and private funding and provision, so with an integrated care and funding approach. Why is this important? Because with a structure that combines these two features, we can also be flexible in our solutions instead of delaying, which is typically our natural response to crisis. So we identified a number of prerequisites. I'll guide you through some of them. I think it's interesting to also be part of a debate that I think it's becoming more and more important in the Australian context. We identified several of these preconditions. Some are really to improve efficiency. Some are really to improve equity. The ones, I will summarize them for you, the ones that really are pro-efficiency in the healthcare system, they all speak about the protection of choice. To have that, we need a number of things, all regulated. Transparency in the information, we need protection of competition rules. We need to have accountability and responsibility of those who actually provide the care and also pay for the care. In most systems, this basic concept is absent. If I ask you, who do you think buys care in the Australian context? I'm sure that I would get at least 4 responses, but none of them would be right, because the Commonwealth doesn't buy care, pays for care, part of care. The states don't buy care, they pay for some care through taxation. Ultimately, the insurers, they don't really buy care. They pay parts of the care that you as an individual purchase when you need it. You have to find your surgeon, your anesthetist, and so on and so forth. So the only one ultimately who buys the care is the one that has the least ability to do it, which is the individual. And when out of pocket go up, that becomes a problem. Now, so we need a set of rules that we have been able to create in other markets, so it's not impossible. Telecommunication is one of them, where you basically also have clarity about who buys and who provides care. And there is no conflict of interest between these two parties. Now, for equity, it's equally important. We all pay the Medicare levy. We all take a rebate or the Medicare levy surcharge lifted if we buy private insurance. Do we use it? Do we don't? There are a million of ways of looking at this problem, but the truth is that we really don't know how many times we're paying for the same thing and how many times we're paying for others to use that service. That means basically that we have no idea about a concept that, it sounds really terribly, which is cross-subsidies, which is basically something that should be explicit because it's a transaction from rich to poor, from low risk to high risk. That transaction is the most intransparent when you apply to the healthcare market that you could possibly imagine. So that needs to be clarified. We also need clarity about our contract. What is it that we are paying for? We have a rough idea about some of the subsidies in the APS and the PBS. If I ask you about private insurance, I'm pretty sure we won't know exactly what we're buying when we buy those products. We'll discover it when we need it. Without these basic concepts, these basic characteristics, we really can't hope to come out of the crisis. And clearly we need affordable. The dream to be a dream needs to be affordable. And I call that affordable out-of-pocket payments, which is key. How do we do this from now? Now, you can do it in several ways. Basically, you need to integrate the several systems that we currently see. That's an immediate efficiency improvement. Some countries have done it. The Dutch, they decided to go fully private. In the Dutch, they have regulated private insurance, buying care from regulated private providers. Obviously, I'm no one to say that this should be the model for any country. This is a political, societal preference of the people. Maybe you don't trust the private sector. Maybe some do. So that is clearly a choice. And of course, there is the other option. Because in fact, public and private in all this don't matter. The type of the entity legally defined really doesn't matter. It's important what their functions actually are and how we ensure they perform them. So I'm pretty comfortable with the Dutch model, for example. What you need in this model is, of course, identify on the constellation of potential purchasers who is the best place to buy care efficiently, effectively, at an affordable rate. The UK model in the 90s started to go in the direction of identifying GP, they called them GP fund holding. They became then primary care trusts. Now they're called hospital trusts. These are effective conglomerates of providers that have a risk-bearing function. So they act like providers / insurers, integrated as far as primary care is concerned. That could be a model. Some other countries think it should be the state. Some others think it's the employers, the US employment-based model. Some others think it should be pure insurers like the Dutch. This is clear, but what needs to be accompanying that is a separation between the purchasing function on our behalf, on behalf of the consumers, and the provision function. We need to have somebody that buys cares for us, and that buys that care that is deemed to be accessible and affordable for all. We are unequipped to buy care. Literally, think about the level of technologies. I can't keep up, honestly, and I really spend a lot of time trying to keep up. The important element that I was referring to before, market power, you can only really deal with it if you are clear about the contractual relationships between parties. The truth is that we don't know. Everything is very implicit in the healthcare sector. Now, the good news, and this was to my surprise, some people, of course, everybody was terrified during COVID and we had a terrible experience, but the one good news during COVID was that actually for 2 years or 3, we were able in many countries to realize this dream. All of a sudden, private mix didn't exist. The boundaries blurred. We had a purchaser, the state, the Commonwealth. They did everything from vaccine to provision of vaccines. You might remember that time. So this slide is just to tell you that we're perfectly capable of actually doing this. Now, Australia. I asked my question whether this is a global recipe that we can adapt broadly to different countries. I asked myself also whether all these preconditions are met in Australia. This is a very difficult exercise. Yeah, sorry, short for regulated competition. I did very well because normally I use a lot of acronyms, but so PHI stands for private insurance. So the system, as I described it before, it's a real maze of public-private provision, of public-private funding, a lot of duplication, a lot of overlaps, at the same time a lot of fragmentation, a lot of disparity between urban and remote, even within urban communities. Now, all the problems that I described before, I just put them there to refresh you. They are really urgent issues. Waiting times are going up. Workforce is in trouble. Out-of-pocket payments on the rise, etc. All at the detriment of quality of care, ultimately access, efficiency, and so on. This is very long. I mean, I just put it there because I think it's a way for me to indicate how difficult it is to actually look at our institutional settings and actually score it. So we have been running this exercise in a number of countries. In terms of the institutional settings, the preconditions to actually create an integrated system, Australia is well placed. In terms of how we do in protecting choice, in guaranteeing and being explicit about what we get for the money we pay and also the value in terms of quality of life, we're not really very close to perfection. In fact, we're quite far. But we have the building blocks. That's the good news. The clear issue, the most sensible way to address it, and the one that causes most problems is the absence of this purchasing entity, however we want to define it. That should be really the discussion in the political spectrum. Now, what does integration mean? And I'm really close to conclude. Is really bringing together the various pieces of the puzzle as a very first pragmatic step. How can we do that? There needs to be a clear investment in this integration. All we see instead is really what we call the blame game. I mean, I'm sure all of you have heard about this. The investment in integration between providers, between payers is fundamental. Without that, we can't hope to achieve any sensible purchasing of healthcare in an affordable way. That requires the strengthening of our governance structures, which has a political difficulty because we are a federation. However, if you want universal access, you can't have differences across states to the extent that we do have at the moment. Obviously, you need to strengthen our regulatory oversight. I give you an example. We have a private insurance market with 38 insurers competing since I don't know what year. The ACCC, which is the authority that looks at competition in all markets, has hardly ever looked at practices in private insurance. This, for me, is a mystery. And the reality is that they don't have the resources to look at everything. So we need to build the infrastructure in the regulatory space. Of course, that also means that we have to re-engineer how we perceive the MBS and the PBS and maybe even challenge them. Obviously, we're paying far more for each item. Hardly anybody bulks bill. You saw it in particular in this region in the last 6 months. We're not doing great in terms of bulk billing. So we really need to re-engineer that concept and create an idea of prepayment so that we know how much out of pocket we will end up paying when we actually cover for public entitlements. Finally, we need a system that is more explicit, flexible, that allows innovation to be absorbed not only by the top-tier individuals. Now, to do all this, us economists talk about this healthcare system transformation. Actually, Brandon is here. He's leading one of our groups at HMRI that is really talking a lot about this topic. It's very important. So I think in the Hunter, we are collectively in the business school, Brandon and I and others, really working hard in trying to understand this. All we're really trying to achieve is create the opportunity for a dream system that is capable of providing opportunities in healthcare for everyone, but also absorb the shocks that seem to be so complex to deal with. Thank you.
Well, thank you very much indeed, Francesco. That was amazing and took us on a journey, I think, from where we began and all the complexities of trying to organize a health service that fits our needs to where we're trying to go in the future. You'll be prepared to answer a few questions, I hope. So if anybody's got any questions, please put up your hands. And we have one immediately. Okay, off you go.
So thank you very much for your talk. It was very informative. And I have a very layman, ignorant question. And that is one of the main issues I see in healthcare, at least from my ignorant perspective, is that there is a huge cost in the material that is incurred. For example, insulin or other pharmaceuticals or things that we essentially spend, like equipment that gets used. And it's a very large profit margin for the, let's say a pharmaceutical company. I think insulin, it takes a few tens of dollars to synthesize, but it costs up to 200 or something like that. Wouldn't it allow a great, I guess, help in budgeting if the government could repress these companies in some way to stop them from the massive profit margins?
Yeah. So the answer is yes. The answer is very long, but to make it brief, I think I was alluding to, in a broad sense, supply-side interventions to try and really keep costs down. That's the most ineffective way you can actually do that. So we tend to believe, and I don't know necessarily why, but that government can really come in and stop everything. The truth is that the best way is to actually have the price come out from a contestable setting, of course, governed by government. So in the specific case that you are describing, the degree of market power of the insulin producers is probably one of the most pronounced in the, let's say, in the area of materials. These are quasi-monopolies, duopolies in some cases, depending on the countries that they actually decide to intervene. This is truly something that is an enormous pressure. Australia is doing quite well by comparison. If you look at the price margin in the US context, you'd be shocked. But long story short is that the regulated market mechanisms in that particular segment should be, when you start applying the model in the micro worlds, should follow the same principle. So you can't have one or two manufacturers only in the market. There are far more. You have to make the process contestable, which is not at present, because licenses are actually prolonged year on year. If you have one, and you're performing fine, you don't have any health issues, these type of products keep persisting and having and creating more power year on year. So, yeah, I think I answered by saying two things. Government top-down interventions don't necessarily work. You would scare off industry. And at the same time, you're not guaranteed the supply that you would want. You might remember the vaccine story. That's easier than insulin for most. But also you have to have the structures to allow contestability to occur in a fair way. And Australia, I have to say, in this is doing comparatively better than other countries. We pay less in this specific, but also other areas than certainly the US and in some instances the European.
Thank you very much.
No, my pleasure.
My question was, does the separation of management of hospitals by state versus the Commonwealth managing the sort of primary care, does that impose an additional cost to society as a whole? And would it be better that the whole thing was integrated?
Yeah, this is the exact point I was making. I agree with that statement. In terms of empirics and studies done on the topic, countries that have a clear funding and provision of primary general practice, secondary and tertiary care, and these are the countries that I was referring to, the Netherlands, the Germans, and so on, they have certainly a much more efficient in an economic sense. Not necessarily, the economics of efficiency is interesting because if I'm willing to pay a lot for something that is good, that's efficient. The problem that we have here is that there is complete disconnection and no clear cost saving. I mean, our costs in healthcare are quite high. We look always good in the OECD because we take out aged care. But if you add it, we're up at 14%. The US is 18, we're third or fourth globally. Okay, so this is a very important point that you're making. When you integrate the different components of the continuum of care and you actually collapse them into, you can call it a package that is managed by someone that actually purchases for you at risk to some extent, you have an immediate efficiency gain. This is theoretically proven, empirically tested. Then the question is, why are we not doing it? And the answer is clearly political. I can see that very clearly. These are big vested interests. The states would like to take over. The common, or if you look at the federation history, that's the takeover where it's a kind of an interesting question in itself. The Commonwealth would like to take over. So that tension has delayed a long overdue reform, which is in the sense of integration. But the answer is yes, it's empirically and theoretically proven.
Someone over here.
Hello. My specialty is in ageing. I just wanted to clarify, because I did hear a lot of speaking around that, ageing is really an advanced society problem, but, we do have, come 2050, 2/3 of the population aged over 65 will be in low middle income countries. So it is a global issue, not just an advanced issue. But my main concern is, being a country girl, is short markets when it comes to healthcare. And I'm kind of going, well, how is this system going to improve the issues that we already have around access and quality medicine in country areas that I don't see how it's going to make that jump into improving healthcare out there?
That's a beautiful question. I actually, at the time when I first came here in 2007, some of you may recall the National Health and Hospital Reform Commission by Kevin Rudd. So I had the privilege to work on one of the proposals, made to that group. And, we gave it a name. We called it Medicare Choice. In the proposal, it got a very bad name in my view. They called it Medicare Select, which for me, it's like the worst marketing choice you could make if you want to launch a new idea, which was essentially, the initial ideas on what we discussed, integration, etc. Now, a critical issue that you're alluding to is the issue of regional differences. Now, so that issue, you can look at it in many ways, but the truth of the problem is that from an economic standpoint, healthcare providers will not really go there if you had a pure market approach. So the model that we currently have, which is largely a public model of delivery of care, mixed, because we actually send a lot of physicians, the locum, you might know this terminology, to keep the hospitals open. You need to have the FIFO, fly in, fly out type of services as well to complement. But large hospitals, for the problems that may occur once a year in those areas, are not possible. They wouldn't exist in a pure market setting. So the public solution is what we have found, but of course we ration it because it's part of the public system. So we can only go to some extent, and then we find some solutions like the remote, the digital care, the FIFO and so on. So how does this model address the issue directly? So when you build cross-subsidies in economics, in any areas, basically you're building a payment that goes to a provider, that goes to a payer, that goes even to an individual in a voucher type of scheme. That payment carries information typically on your risk. And your risk can include your regional connotation. So your risk profile, where you live, where you develop, where you work, where you basically decide to live, can carry a risk code. Typically you can measure this very simply. Now this is technical a little bit, but I can adjust my subsidy, my payment, and this is a political decision, according to that particular regional adjuster. So that services, which are an expression of health risks, would be matching the risk of those populations if that is a political decision. Now, I give you an example of where this exists. It exists in Holland, it exists in Germany, it exists in Switzerland, it exists even in the US, also in Israel, to give you a sense of the political tension of this. So in Israel, the risk adjustment model for many, many years was only based on age. Because if you add, for example, region, which could be at the level of the zip code, Arabs and Israeli don't live in the same neighbors, or you could add other factors, for example, gender. Arab women make more babies than Israel. So to give you a sense of how political this can become. So if you put it in the Australian context, where we don't have, an ethnicity issue at the regional level, you can think about what are the needs of these people, which we know, and we do in terms of burden of disease. That's a start. Well, it's a good start, because if you have prevalence of diabetes, if you have prevalence of addiction or consumption or overconsumption of alcohol, you start. This is dynamic. It's not, it's not that we're gonna get there at once. We're gonna have to work on it and understand it. This is also a good way to understand this data better. I hope I explained. This is yeah. Thanks. This is a beautiful question. Very technical.
This is an amazing topic. So much to it and so many aspects to consider. Given that you talked about one of the ideals for a good system would be to deliver value for money and quality of life, what do you think about the idea of financially incentivising individuals, say, to adopt lifestyles that in turn minimise the health risk, their own health risks? So, they're being held accountable in some ways for how they live. Obviously, you've got to have a flaw to all of this, but interested in your thoughts.
Yes. All right, this we need another. I wrote a book about this, in fact. No, not a book, a full chapter. I call it the Financials and Economics of Consumers' Responsibility. Now, this is a huge topic. It's fascinating. It's a beautiful topic for an economist, because you have clearly, on the one hand and on the other hand type of conversations. Now, I think there is a lot that we can learn from behavioral economics. Masfin is a guru in this, is one of our researchers there who just joined us. That really you can become very clever in constructive incentives, both financial and non-financial, to actually make people choose what they want. There is a clear example of what you eat at a Mensa or in a cafe at work, right? So if you display sausages and burgers like in the front row, I guarantee you, we're gonna go for them. If you put salads. So the question really is that we have a lot of knowledge on how to design incentives. Now, the actual policy aspect becomes extremely tricky, mostly from a legal side. I give you an example. Why does Australia have one of the harshest smoking incentive aggregate policies in the world, if not the hardest, and has one of the lightest policies when it comes to alcohol access and consumption? So I'm not expressing an opinion. I love wine. I'm Italian. I mean, here there is no discussion about that. But the complexity of policy making. So, long story short, you're spot on. That would be a massive achievement in a generation of policy making, to have a set of incentives, compatible schemes. We can do it for incentivizing individuals to eat better, to drink better, to move better, and even subsidize it, because then the other issue is the price. And also, you can believe, on this I'm far more skeptical because the evidence is not there, that the apps that we have to make us exercise, that is a far more complex equation. The change in lifestyle and in movement, in physical activity. Also because it can be very dangerous, to shift from 0 to some physical activity, so the literature there is more complex. But on the other hand, to answer, yes, it's a great idea. You delay care, if not maybe even never need care. And then I give you also the other hand, if you allow me. There is a study from the Netherlands that actually built in a simulation the actual costs increase that you would have for people living very long, which is an interesting study. I say it in a paradox because we're coming close to the end, but it's interesting how you think about these things. Because, of course, the longer you live, the more degenerative diseases you may develop. And so what is really the break-even point here?
Look, can't thank you enough, Francesco. You've really opened up a very exciting area. There's lots of complexity. Designing health services is always complex because we walk on shifting sands. And the situation that we have now will not be the situation in 10 or 20 years' time. So the complexity is there, but you've really opened it up for us and you've excited a lot of discussion. So on behalf of George Willis, who's the chair of the Hunter branch of the New South Wales Royal Society, we'd like to thank you for coming and giving us this talk. And I would like to thank all of you for coming to this evening. It's been a great and very enlightening evening for us all, I think. So thank you very much indeed.